Hello, I'm Dr. Russell Libby, and welcome to the world of medicine. You know, on the show, we learn about important topics, conditions, types of things that go on in healthcare and medicine from people like you and me. We have a studio audience. They're going to talk about their experience with a specific type of condition. Today, we're going to talk about diseases of the colon. We're going to talk about colonoscopy. We're going to talk about the kinds of things you discover when you do colonoscopy on an individual patient. We're going to look and talk about the experiences people have had with colon cancer, ulcerative colitis, and Crohn's disease, possibly some of those inflammatory bowel problems, as we call them. We have a number of really neat topics to cover. A little queasy for some, but really very interesting and very important. Colonoscopy could be the most important thing you do as an adult in your life. And we have an expert here, Dr. Michael Garone. He's a gastroenterologist here in Northern Virginia, one of the finest out there. He understands everything that we're going to be talking about, and he's going to fill in a lot of the information and the gaps that we need filled in so that we all have a good, clear understanding of what is going on. Now, with our studio audience, they've all had some experience either directly or indirectly through a loved one with colonoscopy and some of the diagnoses that might be decided upon by that process. When we talk about colonoscopy, you go, you have a diagnosis. I want to know, what was it that was diagnosed for you?
Colon cancer.
Colon cancer. And how old were you when that happened?
Probably early 50s.
Okay, we're going to find out more about that. Have you had colonoscopy?
I have had a colonoscopy. Yes. I was clean as a whistle.
Clean as a whistle. That's
yes.
a good thing to know. Yeah. That's a great perspective because you've survived.
I survived.
You survived, because I think people have a lot of fear about it. We're going to talk about colonoscopy.
Yes, colon cancer.
Colon cancer, okay, so it's a big topic, colon cancer. We know that colon cancer is a major health problem in this country, that probably 60,000 people will die from colon cancer. There will probably be somewhere close to 160,000 new cases diagnosed this year. It's the second leading cause of death by cancer, even ahead of breast cancer, and you hear a lot about these things, so it's important. And I know that you've had...
I have not had a colonoscopy.
You have not had a colonoscopy.
However, I will turn 50 in a couple of months, so I will look forward to my very first this year.
All right, and we're going to talk about that too. When do you do it?
Hi, colon cancer.
Colon cancer, okay.
Ulcerative colitis.
Ulcerative colitis, so we have our first of the inflammatory bowels. All right, that's good.
Relative with colon problems.
Colon problems, okay, here we go. And we have certainly...
I had colon cancer. I've had normal colonoscopies and polyps that were non-cancerous.
So you've run the gamut. It sounds like you've had the experience a few times. You can give us some insights.
Yes, I can.
Yep.
Yes, I have Crohn's disease, and also my father died of colon cancer.
Colon cancer. So that's something interesting for us to explore a little bit too.
It was clean.
It was clean.
Yes.
Ah, another remarkably lucky person.
Colon cancer.
Colon cancer. Okay. So colon cancer obviously is a biggie. When we think about colonoscopy, we think about all those people who we hear about, the celebrities. Tony Snow, lately press secretary to the president. Katie Couric's husband, I guess back about 5 years ago. Katie Couric was so taken by the fact that her husband had colon cancer and died at a very, very young age that she actually underwent colonoscopy on television. That was shocking, but you know, they now call it the Katie Couric effect. In that year following her televised colonoscopy, there was a 20% increase in the number of colonoscopes that were used that year on people who were curious and worried. So it has an effect. Did celebrity have any effect on you? I mean, when you had your colonoscopy, was there...
It was 16 years ago.
16 years ago. There were no celebrities...
No celebrities.
...proud about the fact that they had colonoscopy at that time.
No. I'd never heard of it before.
You've never heard of it, yeah. Was it something that you just did routinely as you hit a certain age, or did you have symptoms that made you...
I'd had blood in the stool for some time. We'd just come back from overseas, and nobody seemed to be urgent about it. I thought it was hemorrhoids.
Right.
So,
And back then, I know that colonoscopy has changed significantly. The colonoscopes, the tools that they use, and the ways that they prep you for it, have they changed?
that has
over that period of time?
improved greatly,
Yeah. So
especially the prep.
Yeah. Did you have a lot of anxiety about it when you did it the first time?
No,
No.
not a bit.
And you've been coping with it. How often do you have to have them now?
Every year, 18 months. This last time it's been 2 years.
2 years. Well, that certainly is a blessing. And you've had your one,
I had one,
right?
and I'm not 50.
You're
but,
not 50.
I am an oncology nurse and a hypochondriac. So I actually heard a lecture by a gastroenterologist, a local gastroenterologist, and said, I have had one symptom. I probably should get it checked out. And sure enough, he did that colonoscopy on me, and everything was great. But
Everything went well. Good, good.
Yeah.
And was the experience reasonable for you?
I think I slept through a lot
You
of
slept
it.
through it.
Except
Okay.
the prep.
Okay. Yeah, the prep, it's a hard thing to sleep through, or at least most people wouldn't be too happy about the outcome of that. When we talk about colonoscopy, now, I guess there are lots of doctors who may practice that. Is it a specialty that some types of doctors will do? I mean, obviously a gastroenterologist will do it. Are there other types of doctors who routinely do colonoscopy?
Yeah, there are surgeons. Some surgeons are trained to do colonoscopy. I know that years ago there were family practitioners who were trained to do colonoscopy, but you don't see that very much anymore. Usually it's either a board-certified gastroenterologist or a surgeon trained in colonoscopy.
And they're done in the hospital outpatient settings where typically?
All of that. Hospital, usually if it's an outpatient, there's outpatient settings that I'm sure some of the patients have had in the hospital. And now there's, in most states, they have outpatient facilities where you can get the same procedure, but not in a hospital, as part of a doctor's office or a freestanding building.
And the thing that people seem to talk about the most in their anxiety about it, and I'm sure that you must hear about it plenty, that is the clean out. I mean, it's not even the procedure. It's like, what do I do to get ready? What do people do to get ready for a colonoscopy?
Well, I can tell you, and I think most people would agree to this, is that after if they've never had a colonoscopy, and they're very anxious about it. They're anxious for two reasons. They're anxious because they don't know what to expect, and they're also anxious about what you're going to find. But when it's over, almost every patient says the same thing. That was not very bad. Do you know what the worst thing was, doctor? And I'll say, what is that? They'll say, yesterday, the prep. But the procedure, after they've had the procedure, said that was a piece of cake. But the prep was what, but most people, especially if they get a clean bill of health or if you find a reason why they had symptoms, it's just something to mention in passing. Most people are not very upset about it. They have to take something to drink and clean out. And they look at it as a necessary evil.
Right.
And they do it.
So most people, did you stay home the day before? I mean, you have to, I guess, don't you?
Yeah.
So you schedule it in a way where you can take 2 days?
You were in the hospital.
You were in the hospital?
I was
yeah?
in the hospital, but I think the prep was at home.
Yeah. Okay. Yeah, well, I would think that would be true.
I don't remember when.
Well, can I chime in there?
Sure.
Most people, if they're not sick and not in the hospital, they do start the prep the night before. So most of them will come home. We usually tell them around 5 o'clock.
Right.
So they're usually able to work a full day, do the prep. Just stay on liquids the day before, clear liquids, and they start their prep around 5 or 6 in the evening, and then do it through the evening, and that usually works for them. And then they do the procedure the next day. And because of the sedation, we tell them, well, you really shouldn't return to work that day or drive and that kind of thing. But the following day, most people are back to full activities, and I think most people would verify that.
Okay. And once you've gone through the procedure, I imagine it gets easier, at least to anticipate. Now, did all of you have anesthesia, or did some of you go without anesthesia? Anybody go without anesthesia? So it seems like that's a consensus. Do most people go with anesthesia? What is the process, and what kind of anesthesia do you use?
Yeah, almost everybody receives anesthesia, and I think it's a good idea to get at least some type of anesthesia because it makes it easier for them and makes it easier for me. If they're comfortable and I don't feel hurried to do what I have to do. But I think, there's two types of sedation. What they used to call local sedation, conscious sedation, where they get intravenous drugs given by the gastroenterologist or the surgeon doing the procedure. And most people are either sleeping, a light sleep, but they're still able to be easily aroused.
Right.
More recently, we've been having anesthesiologists work with us and give certain medications like propofol, where they're still breathing on their own, but they're really fully asleep.
Right.
And it makes them much more comfortable, and it makes it, again, more easy for us to complete the procedure, do what we have to do, and then they wake up feeling great.
And in the process of the procedure, I guess show us a little bit about the colon and what you're doing when you actually do a colonoscopy.
Well, just to go through a little anatomy, the colon, everybody always says, do you look at the large colon or the small colon? Well, there's only one colon, and you can call it the large bowel or the colon, whatever you want to call it, or the large intestine. But that comprises the rectum. You got the sigmoid colon, descending colon, transverse colon, ascending colon, and cecum. The cecum is where the appendix comes off, and it's where the small bowel attaches to the colon. And a colonoscopy looks at the whole colon here. And patients who have had a sigmoidoscopy, they've talked about doing flexible sigmoidoscopies. That's the same kind of instrument, only it's shorter. And that usually goes up here into this part of the colon, maybe up to where the spleen is. We call that the splenic flexure. You see the spleen here. So that would be a flexible sigmoidoscopy. And the colonoscopy, again, is the full procedure.
So the sigmoid is something, who would get a sigmoidoscopy? I mean, if you're going through the process of cleaning out and getting a screening, is there any reason to do a sigmoidoscopy?
Well, these days, the reason to do a sigmoidoscopy is only if you're looking for some reason for a recent symptom or bleeding, particularly if you have a young person who doesn't have any other symptoms other than passing a little blood, bright red blood. In most cases, with no family history of colon cancer and otherwise no other symptoms, a flexible sigmoidoscopy will probably show what the cause was, either hemorrhoids down here at the opening or a fissure, which is a tear, and we can usually find that just by doing a sigmoidoscopy.
Right. But for the majority of those screening procedures, now, at what age do you recommend that most people start with?
For the average risk person, age 50.
Age 50.
The only thing that has changed a little bit, and you haven't probably seen this in the news or the literature, the lay literature yet, is in African Americans, the age colon cancer starts to take off is actually about 45 years old. Right. But for the average Caucasian, Hispanics, whatever, it's 50.
Okay, so you have for the routine, that would be the individual without any real family history or other predisposing factors, which we'll talk about in just a minute. So it would be 45 for an African American, 50 for a Caucasian or other ethnic, racial background, whatever. And then how often would they do it after that time?
Again, if it's a routine case and no pathology is found, no polyps or anything like that, and you get a really good look, the patient has done a good job cleaning out, they say 10 years. 10 years.
Now, the issue that, of course, is of most significance is early detection of colon cancer. And is that, what, 90% of colon cancer presents after age 50, although we hear a lot about those who presented before that time. That's the case for the most part. So we're looking for polyps. Polyps are what, I guess, precede the actual cancer in most people.
Right. Usually a polyp will progress. Cancers start as a polyp, but not all polyps will progress to cancer. But you find them at an earlier age. The mean age of colon cancer is about 60.
Okay.
But of course, by then, you've had a polyp for many years that has had a chance to grow. And we know that polyps of certain types can develop into cancer because there was a big national polyp study to see if actually all the colonoscopies we were doing, taking out all these polyps, did it change the incidence of colon cancer? And it turns out it did. So we actually are doing some good, and that's one proof, and that's probably one of the best studies to show that taking out these polyps does prevent cancer. Having said that, not all polyps do become cancer, but of course we don't know which ones. So we take them out when we see them. We take them all out, okay? Because we just can't tell.
So that's an important qualification to ask whoever's going to do the procedure. Will you remove the polyps if you see any?
Right, and they always ask that, and I always tell them the same thing. We can usually take all of them out, except if you find a really big one, or if you find something that's an obvious cancer, right, then of course you can't.
Now there's another test that people talk about called virtual colonoscopy. It sounds like a reasonable alternative to many because it's much quicker. What does that entail, and is it comparable?
Well, it's not comparable in the sense that, well, first of all, you do have to do a prep. You have to be even cleaner for a virtual colonoscopy than you do for a regular colonoscopy because What a virtual colonoscopy is done by CAT scan. Most people know what a CAT scan is. But it's a special way they do the CAT scan to look at the colon. And you have to be extra clean because the CAT scan, when it's looking at things in the colon, they can't tell the difference between stool and a polyp very well. Okay, so you have to be extra clean, and then they blow you up with a lot of air, and it's very uncomfortable. And then here's the fun part. After you go through all of that, and they find something, now you need a colonoscopy.
Right.
So right now the recommendations are not to do that because of the reasons I just said. You end up with a virtual colonoscopy and a colonoscopy. Also, they miss things that colonoscopy pick up. So overall, right now, although the technology may change, right now the recommendations of most societies are, if you're going to do screening or you're looking for symptoms, colonoscopy.
Colonoscopy, okay. So the virtual test also has a lot of radiation. From what I understand, as people have equated it to somewhere close to 200 chest x-rays with one study.
Well, that may be the case, and that's another downside to doing x-rays in general. But again, if it was a screening test and you said you don't need it for 10 years, it may not be that big a deal.
Right.
But it is another factor. But the biggest factor is it's not as good as colonoscopy. You may need a colonoscopy anyway, and they miss things.
Right. What are some of the symptoms anyone might have had that maybe had directed them to have their colonoscopy? You had some bleeding. Mm-hmm. Anybody else have symptoms that precipitated their initial exam before they really were scheduled on the routine? Did you have some experience of that nature?
When I was first diagnosed with intestinal cancer, I had fatigue, which turned out being from anemia, and sweats and chills at night, which was due to spread of the cancer.
So you were sick, and that was part of the workup because did you have a occult blood test of some sort for your?
No, I did not,
No.
and I was having no abdominal pain,
No
no nausea, no vomiting, no diarrhea. Just felt tired, thought I was working too hard, and then I got sweats and chills, thought I had the flu. Then I got a blood test, knew it was not right, and saw the gastroenterologist, Dr. Garone, and the rest is starting to fill up my medical chart.
An extensive history there. So your basic fear was that this is the time of life where you can experience that kind of cancer, or was it something else that made you think it has to be something like that?
Oh, I saw my blood test results.
Yeah. Okay, so did you have the CEA or one of those types of things that were done?
Well, that was, Dr. Garone ordered that, and interestingly, it was normal, so it was not helpful at all for me.
All right. Well, that's interesting. There are other screening tests that you use as well. You have other kinds of x-ray studies that people sometimes do.
Well, let me just say, first of all, the most common presenting symptom, if you will,
Right. Okay.
for colon cancer is occult bleeding, not frank bleeding. And patients will present with fatigue
Right.
or hidden blood in the stool. And the fatigue is usually from anemia, from losing little bits of blood over a period of time. So that's the most common way to present. And then, of course, you can have other things like rectal bleeding, change in bowel habits, abdominal pain, weight loss, things like that. But what was your other question?
Well, no, the other screening tests, and that brings up, you say, so sometimes this slow blood loss makes you anemic. One of the things that when I went through my training, everybody had to do the occult blood tests. In other words, there's little cards that you would smear some stool on and then giggle as you sent to your doctor, thinking, how could they open the mail when they know these things are coming in? But in fact, those were important tests at that time. They were one of the only screening tests that we used.
Right. We don't use fecal occult blood tests much anymore because it's one of those things, if you have a patient, for example, who is anemic,
right.
If you do a fecal occult blood test, which are going to be positive only about 50% of the time in cancer, if it's positive, you're going to do a colonoscopy to find out why they're anemic. If it's negative, you're going to do a colonoscopy, so it's a waste of time. And so you're just going to go ahead and do the test. And that's the same thing with screening. That's why we don't do fecal occult blood tests for screening anymore, except for there are some people, and it's still approved by the American Cancer Society, which I don't agree with, that doing the fecal occult blood test and a sigmoidoscopy is an okay alternate to screening. I don't agree with that. Most of the other societies don't agree with that, and most people don't do it. And if I were a patient, and most patients know that if they want to get checked, they really want the whole colon checked, because they'll ask you, well, you looked at this part, what about that part?
Right.
And I'll say, you're absolutely right.
So you're saying that basically people don't do the barium. Now, once again, there's another test called a barium enema where they do x-rays, but they use a contrast material, something that will show up the inside wall and show some defects there.
Right. A barium enema is an okay test. I told you the virtual colonoscopy misses polyps maybe 10% of the time, maybe 15. The barium enema will miss polyps, and significant polyps are described as polyps greater than a centimeter. A centimeter is about 1/3 of an inch. They'll miss them about 20 to 40% of the time. But we will do a barium enema or a virtual colonoscopy or something else if for some reason we can't get through the whole colon.
Right.
And there are reasons that sometimes that happens.
Okay, so the state of the art, the real recommendation is if you're going to screen for this, you want to do colonoscopy. Now, you had your colonoscopy.
Right.
Was this just a routine, it's time? And
Yes,
something was diagnosed? Were you sick? Did you feel sick when you had?
No, I wasn't
Any presenting
sick.
symptoms?
I was 52, and I said, well, it's time. It's past time. I should go in and get a checkup.
And?
And I had colon cancer.
So here you went in sort of la. I'm okay. I mean, this is just one of those things I have to do. I go to my different doctors for the different screening tests, and it's at the appropriate time. And you came out of anesthesia, and was somebody there to talk to you about this?
Dr. Garone was there to talk to us, and my husband was with me.
Right.
And so basically you have a problem. You need to go see a surgeon, and here's why. He had pictures for us showing the area that he was concerned with. And that's when the ball started rolling again.
And I guess it took a little while. How did you guys adjust to it, you and your husband?
How did we adjust to?
Yeah, I mean, it must have been shocking. Right now, you're certainly
well, it
well
wasn't the
composed,
first.
so things are going well for you. Yeah.
Yeah, it wasn't the first time I had a diagnosis of cancer.
Yes.
So it was one of those, like, oh great, here we go again.
Right.
And so you basically gird your loins and let's go and let's get something done about this.
Okay. What was your other cancer?
A uterine cancer.
And when was that diagnosed?
When I was 38. So I was very young.
You were very young for
right.
that, yes. And, typically it's a surgical approach. Did you have
Yes.
chemotherapy, radiation? Or
A radiation and surgery.
Okay. So you have one of the predisposing conditions that we think about that would put you at an increased risk.
Right. And well, and again, at that point, there weren't the studies,
Right.
saying, oh, there's a correlation. People with this now are getting this and that. When I first had the first diagnosis, that correlation wasn't made. And so you just kind of go along and you think, all right, I'm approaching 50. It's now it's time. Got to do this.
Okay. And how long ago was that?
That was 3 years ago, 3.5 years ago.
Good. And your condition right now?
Good.
Good. So you're considered in remission or cured or whatever it is for the moment.
Whatever.
Until,
I'm alive.
You're alive. Good. Good. And thankful for that.
Yes.
So we all. And
Russell, I just want
Yes.
to say all my patients are cured. So.
well, that's great. I think that's. I said you were a miracle physician, and really a great one at that. And you were talking about a combination of conditions, but one of which was colon cancer.
Crohn's disease.
Oh, Crohn's disease, and then a predisposition, or did you have
Well,
the diagnosis as
it apparently runs in my family. My father died of
Okay,
it.
I see.
In fact, he had nothing but the sigmoid scopes his entire life,
Right.
and they missed it. And when they finally went in and did a colonoscopy, there it was. When he was 69, and 5 years later, he was gone.
Right. Okay. So, did that prompt you to have your initial screening earlier, or were you symptomatic in a way that got?
Well, I mean, that's a good reason to have regular screenings, but because I have Crohn's disease, I also had a resection of my colon and small intestines due to Crohn's disease.
Right.
So he goes up and looks at the anastomosis to make sure it's okay, it's open, and also I guess he's looking for cancer as well. So I do it every 2 to 3 years.
Okay. So you have an important reason to do that. And what are some of the risk factors for people to consider for colon cancer?
Well, inflammatory bowel disease is one, particularly if you have inflammatory bowel disease, Crohn's disease, or ulcerative colitis involving the colon. Family history is very important. People with a family history. The lifetime risk of colon cancer in this country is about 6%. You run about a 6% risk. If you have one first-degree relative with colon cancer, you triple it to about 18%. Okay? That's not counting people that have another hereditary form of the disease, but that's only 3 to 5% of colon cancers. That's the hereditary non-polyposis colon cancer syndromes, and those are the ones associated with uterine cancer and ovarian cancer and other cancers. That's a separate entity, but that's different. That's only 3 to 5%. Then there are people who have another genetic condition called familial polyposis that comprises about 1% of all colon cancers. But 90% of colon cancers or more are the sporadic, I mean they just happen. So risk factors are family and pre-existing conditions like inflammatory bowel disease. Also, what we're learning more and more, and people are tuning in more to it, dietary factors. Right. People that have a high diet in animal fats, meat, okay, have a higher risk. People that drink too much alcohol, I think like you do. But,
right. Well, that was when I quit smoking because I didn't want to get lung cancer. So
right. And actually, smoking is another risk. Right. Smoking, lack of exercise, obesity, risk factors, and things like that that contribute to it. So we can actually affect how well we do and decrease our risk. And actually, since you're talking about risk, I just wanted to mention, there's been studies before, and there was just another new study that came out that particularly people that have a little higher risk of colon cancer, they're taking aspirin every day. A lot of people take an aspirin a day to prevent heart disease. That's low dose. The problem is in preventing colon cancer, you need a higher dose, 300 milligrams, as opposed to the 81. So you say, well, that's no big deal, I'll take an aspirin a day. Well, it's a big deal if you develop an ulcer and bleed. Right. So you have to judge, everything in medicine is weighing risks and benefits. So if you have someone who's had a history of colon cancer, maybe history of multiple polyps, strong family history of colon cancer, not a bad idea for those people to be taking aspirin. At least 81, but probably the 300 if they can tolerate it and they don't have a history of ulcers.
Right, and 300 is basically one regular tablet.
One aspirin.
One aspirin tablet. And every day, every other day?
Every day.
Every day. And of course, no one's, let's say, committing themselves to saying that's an absolute prevention mode. But also there are the statins that people have been doing some studies with as well on.
The results on statins are mixed.
Yeah.
And right now the recommendations are not to prescribe statins to prevent colon cancer.
Okay.
But you know, those studies may change. But right now there's no recommendation for that because you run risk of other things with taking statins, liver disease and other things.
Right.
But certainly taking an aspirin a day and modifying your diet and your habits, exercise, keeping your weight down, don't drink too much, don't eat too much meat, listen to everything your wife tells you.
Sounds like the right kind of advice. It sounds like the cure for every disease state out there, in fact.
Listening to your wife?
Right. Yeah, no, that is a disease in and of itself sometimes, but not for the moment. Your experience with the colonoscopy and the outcomes.
Oh, okay. I went in, I was 51,
yes.
and it was just time.
Yes.
I'd had irritable bowel syndrome
right.
for many, many years, and that was actually improving. So there was really no change in that. There were no real symptoms.
Okay.
And I found out that I had stage 3 colon cancer. So it was a huge surprise.
Huge surprise. So you were feeling pretty spry. You were feeling reasonably healthy.
Absolutely fine.
And when you talk about staging, I mean, just give us a basic breakdown as to what that meant for you.
Okay. Well, it was stage 3. I actually didn't know it was stage 3 until after surgery.
Right.
But that means that it had spread to the lymph nodes.
Okay.
And that meant that I had to have chemo. They couldn't take care of it surgically. I had to have 6 months of chemo.
Okay, so once it's left the bowel itself and gone to other tissues surrounding the bowel, or even, I guess, what is it, stage 4 is where it's in distant tissues?
Distant organs.
Yeah. So stage 3 is a pretty serious spot to be. So you came out of colonoscopy, you were surprised. How soon after that did you have your surgery?
10 days.
10 days, okay. Gave you not much time to think about it, but I'm sure you thought about a lot. It brings you to in touch with some pretty significant basic fears, I'm sure. The surgery went okay?
Surgery went fine.
Okay, and then you started chemo. How soon after that?
About a month later.
About a month later after you'd healed adequately. How long did you do that?
Chemo was 6 months.
6 months. And you coped with that pretty well?
Actually, I did very well with the chemo.
Good.
Yeah.
So you're a sturdy person. You're healthy as it be.
I guess so.
How long ago was this?
The chemo ended in October.
Okay.
But I continued on Avastin under a clinical trial for another 6 months, and that just ended in April.
Okay. And have you had scans or colonoscopy since then?
I had a scan, and it was clear.
Okay, great.
And I'm going to have a colonoscopy in 3 weeks.
Okay, good. So you're keeping your fingers crossed?
Oh, yeah.
Oh, yeah. We all will for that, for sure. So how often is it that you will see, you know, I mean, you do a fair number of these studies. How often is it that you'll have somebody come in with no symptoms and then they will have a diagnosis come after that?
It's pretty often, actually. And the thing is, and that's why people need to, if they have symptoms, to come in as early as they can so we can find these things early.
Right.
Or at the age of 50 or soon after to start getting screened. Because if you look at the curves, again, starting at age 50, the risk of colon cancer is just a straight line going up.
Right.
Actually, if you can make it to age 80, it sort of plateaus, and the risk actually goes down again.
Yeah, they say if you live longer, you have longer to expect. That's true.
Right. But you know, the thing is, to paraphrase Yogi Berra, you know, getting a 90% of getting a colonoscopy is half mental. You have to, you know, just get over the idea. It's sort of like mammograms years ago. You know, women say, why should I go for a med? It's painful, it's uncomfortable. I had my mother, you know, she would use me as her doctor, although I preferred she didn't. But I made her go for a mammogram, and I had to hear about that for probably months. And then I finally told her, you have to go for a colonoscopy. And she finally went for that, and she survived it. I barely did, but she survived it. But the thing is, just getting past, you know, doing the procedure, and a lot of people, now people talk about things. They go for mammograms, they go for pap smears, they get colonoscopies. It's not, the same stigma is not the same as years ago where people didn't want to talk about these things. Now everybody talks about it, and it's good.
Well, she trained you well.
She trained me well.
She did, yes. And she got you ready for adulthood, that's for sure. And so you have to do these screening tests, basically. I mean, it's included in your Medicare coverage. Most insurance companies will cover this. They will pay on the routine for at least a routine scope every 5 to 10 years.
Right.
Starting at age 50?
It's starting at age 50, and Medicare will pay for it, you know, for people 65 or if they have Medicare younger. I have to say, and this is a sad thing, I've had patients that other people, and even I have done sigmoidoscopies years before because that's all Medicare would allow. The stool cards, which I said were not always very accurate, and sigmoidoscopies. And then several years later, they come back in and said, oh, now Medicare said they'll allow me to have a colonoscopy. And they do a colonoscopy, and sure enough, they had a colon cancer on the right side. And it's unfortunate because if we'd gotten the government to allow it sooner, we could have been doing them a lot sooner.
Anything that you've ever heard that you think was important that people can do other than, of course, being screened that might help them prevent colon cancer?
I think the screening is the most important.
It is the most important part.
And he's right. People do talk a lot more about it.
Right. Well, there's a huge industry out there of, one might say charlatans, other might say opportunists, but some may say healers who will do things like provide nutritional supplements, sometimes cleansing routines, enemas, high colonics as they call them. Did any of those things cast your thoughts?
No, again, it was so long ago that it wasn't.
It wasn't stylish
then.
Okay.
Right.
I see. Okay. Anybody have any experience trying to seek out alternative methods to deal with a colon cancer? So it's when you're faced with the real diagnosis, it's a little harder to turn to those sorts of things, I suppose. But is there any fact, fiction, any reason for people to pursue nutritional supplements or any other form of prevention?
Yeah, the only other thing is that particularly people have had a history of colon polyps or colon cancer again, but even in the general population, taking extra calcium, particularly with vitamin D, 1,200 to 1,500 milligrams a day. This is an easy sell to women because they need it for their bones more than men. But if you don't have a history of kidney disease or kidney stones, taking extra calcium helps.
Okay.
A lot of people looked into things like selenium, which it turns out probably doesn't help, so you probably shouldn't take it. You know, you can take the trace amounts that come in multivitamins. We used to think folic acid. Taking extra folic acid may help prevent polyps, but interestingly enough, when they did this study on aspirin, and they found that the aspirin helped, they also looked at folic acid, and it turns out that in this huge study, that it turns out folic acid didn't help, as previous studies had shown. So taking some folic acid probably doesn't hurt, but it doesn't help as much as we thought.
So there's no real foolproof prevention that you can go through other than screening and making sure that you exercise, get plenty of fiber. Does that have anything to do with it?
You know, it's unclear. You know, I tell all my patients, low-fat, high-fiber diet.
Right.
And the studies, and in fact, when you read the studies, they'll say it's unclear, is it the low-fat or is it the high-fiber? It doesn't matter, because we know it probably helps you. It's probably good for your heart. It helps to prevent breast cancer. We know that low-fat, high-fiber diet helps to prevent breast cancer as well. So it's not a total loss no matter what. So is it the low-fat? Probably, because if you look epidemiologically at the world, the low-fat diet countries are the ones that have the lowest risk of colon cancer.
So our high-tech world here goes low-tech for just a few minutes, I guess. Either the batteries or something of that nature happen there. Now, well, your battery won't run out. You're the ever-ready bunny. I know that. But now you work with patients with cancer, or you help with families and situations?
Yes, I'm an oncology counselor at Life with Cancer,
Right.
and we provide support and education with nurses, oncology nurses, and either clinical social workers or licensed professional counselors, free of charge to patients and their family members, their children, and we offer support groups, counseling, and complementary therapies.
So there are probably a lot of things that go on in the process of getting diagnosed personally, you know, in terms of their own lifestyle, their own existence. It may really interfere with their ability to take care of their family. And those are the kinds of things that you approach, and you help them through the process of assimilating into whatever treatment category they have to go into.
Well, I think initially it's that understanding what it is
Yes.
that I have and the treatments, the education piece, and then it's what's going to happen to my life. You know, my family, my job, how much time is this going to take? And some of the patients here would probably have a more articulate, be more articulate about how it affected their lives.
Sure. And this is through an Inova-based foundation?
Mm-hmm.
Yes. So if people are interested in finding out about it, they can...
They can check out our website, lifewithcancer.org,
Okay.
and they can see all the programming that we offer and contact us through there.
Okay, and I'm sure that there are some links there to some pretty informative websites. Now, we have a whole other category of disease that would be evaluated through colonoscopy. You had a colonoscopy because...
Because I was having bloody diarrhea, and my husband told me he would divorce me if I didn't get it done.
Yeah, I can imagine that somebody has to slap you into shape here and get you on the road to recovery. Was this something you'd experienced before? Was it something that through your lifetime you'd had episodes that you just sort of ignored?
No.
No.
I had never had any problem before. About 6 months before I started having bloody diarrhea, I started to have smoky vision. So I went to the ophthalmologist and I had uveitis, which was some form of autoimmune inflammation. Mm-hmm. And didn't have any other symptoms at that time. Then I was planning a trip out of the country and I started to have bloody diarrhea, and of course you can't get in to see a doctor quickly. So my brother had ulcerative colitis and had to have a colectomy done. And I thought, well, you know, I also work in pediatrics, so I could have had a GI thing. Sure. And so I said, well, let me take some prednisone. If I get better, then I know what I have.
Then I can go on my trip.
Yeah,
right.
So that's what I did. And then it got better, and, you know, then I had it again 3 months later, and I was doing something else, and I didn't have time to go see the doctor, so I took prednisone again, and it got better. And then my husband got mad at me, and he said, you better go.
So you see, it's not just the wives. The husbands can do it too.
It's usually the other way around.
Right. When we think about something like this, now you say that basically you had a bowel disease that was a primary cause for your eye problems.
Yes.
And that means that you spent 6 months really walking around with that disease without really having a diagnosis that was accurate as to the cause. I wonder how much time that happens. So at this point, you've had your course of treatment and you're dealing with your inflammatory bowel.
Mm-hmm.
Things are in remission, so to speak.
Yes.
And that's working. Your eyes are okay. You're seeing
yes.
well.
My eyes are fine.
Did that require any special treatment as well?
Yes, it was very resistant to cortisone drops, so I had to have injectable cortisone into my eyes.
Yeah, which is always...
And actually, it didn't hurt at all.
Right.
The ophthalmologist said, I have a 5-year-old who lets me do this, and I said, okay, you can do it.
It isn't his 5-year-old, I
No,
assure you that, right?
But it really didn't hurt at all.
That's good.
The colonoscopy was worse, but it wasn't that bad either.
Yeah. Okay. So you've had inflammatory bowel issues. Now, you had a situation where that was a primary presenting symptom for you?
Right.
Yeah. Did you have any of the other symptoms that may be associated with any of these types of diseases?
Yeah, well, I've had Crohn's disease for over 30 years, and I've had situations where I was very sick, lost weight, had a lot of cramps and that kind of thing. So I've been through my entire digestive system, been tested, looked at 50 million times. So I even had the camera test.
Okay.
Which you swallow a camera, it goes all the way through the whole thing.
Yeah, and we didn't really get a chance to talk about the camera test. Do you do that? The little swallow capsule. Did you change your mic, by the way?
I think they did.
Okay, good.
Yeah, we could do it. We don't do it, we read it. It's a little pill, if anybody's familiar with it. It looks like the size of a vitamin. It has a camera at the end. And actually you wear a box, and it transmits the pictures to the box. And it goes through your small intestine. It's only for the small intestine. Patients ask if it's for the colon too, and it's not. And then when it's done, it just passes out in the stool. You never see it. But you go back in, you hand the box in, we plug it into the computer, and then we actually get a picture. You can look at the whole picture of the small intestine on the camera. And the programs are usually set so that it stops if it sees something abnormal, and it lets you look at it. And you can diagnose a lot of things like inflammatory bowel disease in the small intestine.
So do you use those routinely for looking at the large colon?
No, as I say, it doesn't.
It's only for that upper area there.
There's experimental studies on that, but right now it's only for the small intestine.
Well, I'm sure some people are hoping sincerely that process evolves. Did you have any? You had inflammatory components too, or were you were strictly? Did you say that you had some inflammatory bowel problems as well?
No.
No.
Started with cancer.
With the cancer, okay. And has any of the treatment caused any problems for you?
Well, I finished the chemotherapy a while ago, and it was very difficult. The oncologist said he was going to start me on a dose, and when I complained, he said, well, I was just putting you on a dose, and when you complain of side effects, I'll turn it down, and you just didn't complain much. So after that, I complained more.
Okay. Well, you got to learn. You live and you learn. I know that some people would hope, well, gee, that'll let me use the mega dose. Tell us a little bit about inflammatory bowel disease. It's a different category. Obviously, it can be related to colonic cancer. Tell us
just briefly,
what happens with them and what are the major types?
Yeah, inflammatory bowel disease, usually divided into two categories. Crohn's disease, which can be inflammation from the mouth to the anus, can affect any part, and ulcerative colitis, which only affects the colon. And there are inflammatory bowel diseases. And in terms of our discussion about colon cancer and risks, people who have had Crohn's disease or ulcerative colitis, again, if it's mostly in the colon for the Crohn's disease, after 8 to 10 years of having the disease, even if it's in remission, your risk of colon cancer starts going up dramatically. So for those people, no matter what age they are, I see patients that are in their 20s, but they've had ulcerative colitis since they were 5. And I have to screen them and do a surveillance colonoscopy every year because their risk is going up. And same thing for Crohn's disease. So really, age doesn't matter when you start screening those people, especially if they've had the disease a long time.
So there's Crohn's disease, there's ulcerative colitis. Are there other kinds of symptoms they get aside from the bowel? I mean, the typical ones, of course, the bloody diarrhea, that's an important one. But we heard you had problems with your vision, and of course you're too young to have some of those kinds of problems you see with cloudy vision, and you'd wonder why. And so she had an inflammatory process in her eyes. What are some of the other symptoms that people might have early on that actually could precede the intestinal symptoms?
Well, those are called extraintestinal manifestations of inflammatory bowel disease, not to be too technical.
Right.
But you can get various things like eye problems, like uveitis, which is inflammation in the eye. You can get joint symptoms. You can get funny lumps or bumps that are painful on your legs, funny rashes, things like that. And interestingly enough, sometimes those things predate the diagnosis of inflammatory bowel disease, as it did in our young lady here. And sometimes it parallels the disease. So the activity of the disease goes along with the extraintestinal manifestations, and if you get the disease under control, those other things go away.
Right.
So that's pretty common.
In terms of, all right, so you diagnose this, do you use blood tests for any of these, just by the way? You know, we had talked about the CEA test, which was a fairly significant standardized test for looking at bowel cancer. Do you still use those kinds of markers?
Not for screening.
No.
We use that marker mostly if you're pretty sure someone has a cancer.
Right.
Most important to use that marker because it's something to follow later on. Because as you already heard, that some patients, they have cancer and the markers are not positive.
Right.
So it doesn't help you to follow that. So you have to follow them other ways, which is okay. But it's an adjunct to helping us follow them if it is high, and then we know after surgery it goes back to normal, and then we can follow that over the years, or the oncologist can follow it to see if it starts to rise. It might suggest that disease is coming back.
Any other blood tests that you use, for instance, with the inflammatory bowel problems? Are there blood tests or other ways to diagnose? Or is it all through the colonoscope and getting biopsies, as you call it?
No, there are a host of tests that we can use now for inflammatory bowel disease. There are new serological markers, antibody tests that we can now do for patients. Some patients that have had symptoms that people thought were irritable bowel syndrome were actually inflammatory bowel disease. And when you look at the studies, particularly Crohn's disease, ulcerative colitis is a little easier because that presents with bloody diarrhea.
Right.
So the blood you see. Crohn's disease is often more subtle. So those patients may have had symptoms for many, many years before they actually came to diagnosis because their symptoms weren't severe, and they were diagnosed to have irritable bowel syndrome. Maybe they were teenagers, they were in high school. What teenager doesn't have bowel complaints? And so they get ignored until they get sicker. And then when you get the history from them, even though now they're in their 20s or 30s, they'll say, well, I've been sick since I was a teenager. But everybody said it was just, you know, stress or
something
whatever.
else, right?
Something else.
Do they lose blood? Do they become anemic easily?
They can. Particularly ulcerative colitis again, because the hallmark of that disease is bloody diarrhea and bleeding. Crohn's disease, it depends on where the disease is, how extensive it is, and so on, whether or not they become anemic or not, or bleed.
Okay, and when people have the diagnosis, typically they'll go through a workup of sorts. You'll do the colonoscopy, you'll do biopsies always?
Oh yes, especially if you see something abnormal, you do the colonoscopy, you can do biopsies all through the scope.
Okay.
You can take biopsies, you take pictures, then you decide from there whether or not to look at other parts of the small intestine by doing the camera tests or x-ray tests of the small bowel and so on.
Okay, and once you get your diagnosis, what happens then? I mean, how do you work up the patient? Do you do anything else in terms of other system evaluations, or do you just go after treating the specific symptom?
Well, usually once the diagnosis is made and you feel comfortable with that, with or without doing specialized blood tests, and then we start treatment.
The types of things that people will do to sort of take care of themselves, are there diets or any specific kinds of foods that may aggravate or help?
Well, you know, right now, as far as we know, there is no special food or diet other than just general good nutritional health right now. People do get into more herbal things. They go on the internet and look at things like herbal medicines and vitamins and more holistic things. And a lot of those things are not harmful, so I don't interfere with that. Especially as long as they know if they get sicker, they need to come back in and get more traditional medicine. But in some people, they feel it helps. A lot of people are getting into using more probiotics. Probiotics are putting the good bacteria back in the gut. And I'm starting to use that a lot more in my practice as well, and I find a lot of benefit, particularly in patients with irritable bowel syndrome. But I think it may help in inflammatory bowel disease, but there's no studies for that yet.
Antibiotics have anything to do with creating any of these conditions?
As far as we know, no.
Okay. A lot of people would assume that they might, and I haven't seen any evidence to that effect either, so that's good. We concur on that. Irritable bowel syndrome, which is different from inflammatory bowel disease. I mean, you're talking about colon cancer, inflammatory bowel disease. These are both highly genetic and all predisposing you to some significant medical complications. Irritable bowel syndrome, anybody have that diagnosis thrown at them at any point in their lives? So, irritable bowel, tell me about what happened there with you.
Well, I started having cramping and diarrhea whenever I was under stress. And this, started years and years ago. And the stress went away, the symptoms went away. And that's the diagnosis I was given. And
How old were you then?
Mid-30s, maybe.
Mid-30s, okay.
Early mid-30s.
So, and that was episodic, it would come and go, seemingly related to stress?
Absolutely related to stress.
Absolutely related
Yeah.
to stress, yeah. Irritable bowel, is that a dangerous condition? Is it a common condition?
About 60 or 70 million Americans have irritable bowel syndrome,
Okay.
so it's pretty common.
I would say.
And it's a diagnosis made on clinical grounds, and often it's left to the judgment of the physician on how far to test. Often you will get a history that they'll have irregular bowels, constipation alternating with diarrhea, abdominal cramps relieved by bowel movements. And so on clinical grounds, you can often diagnose it. And then sometimes we'll do more tests, x-ray tests, colonoscopies, depending on the age of the patient and their symptoms. What's important is we look for what we call alarm symptoms. So if someone comes in and they said they're 24 years old, since they've been 16, every time they're under stress, they get a little cramps, a little diarrhea, it goes away when the stress goes away. We don't usually do a lot of tests. However, if that same patient comes in who's anemic, they're having joint pains, eye problems, weight loss, they saw a little blood in their stool, that's not irritable bowel anymore. So now it makes us go that next step and look for things.
So you have a condition that may affect people even in their teens, in their young years. Is there a family history in I mean, are there lots of family lines that will have that kind of
it's like a lot of conditions.
Stress focuses on my tummy.
It's so common that it's hard to say. But you get a lot of patients come in, well, my mother had it, my grandmother had it, my brother has it, but then it's a very common problem. But as far as we know, there's no genetic link. Right. But it could be hereditary, but we don't know that.
Well, so people will have symptoms where they have episodes of diarrhea, they get worried about it, they have cramping, they have bloating. They try a milk-free diet, doesn't make a difference, typically. And they come in, they want to get scoped possibly, they want to make sure that they're okay. Do you discourage it if there are no signs otherwise to suggest that they need to be scoped?
Again, it depends on the age of the patient. I saw a patient the other day who was 48, almost 49. She's close enough to need a colonoscopy anyway. Right. She's had a little bit of change in bowels, but then she said, well, maybe she moved around, has been busy doing other things. Right. I'm not going to quibble over a year, because what if she does have colon cancer? And I waited 1.5 years because I thought she didn't have anything. Right. So it's not worth it. And she agreed. Right. She said, I'll be happy to do that, because she didn't want to worry about it either. So again, but if you have a 24-year-old, I mean, I have no problem doing a colonoscopy on a 24-year-old, but if they don't need it, even though the risk of colonoscopy is extremely low, there are risks to the procedure, as everybody here knows, but still, you don't do a procedure if you don't need to.
Right.
Okay. So it's a judgment call.
Okay. Well, one of the things that people will say about irritable bowel is that there are a lot of, let's say, symptoms that would be suggestive of anxiety, and that really psychotherapy ends up being more helpful for a lot of these folks than actually any kind of medicine, as in, taking medicines to calm the bowel or to slow down the stools. Would you say that that's a possibility? Did you feel like you were having a lot of anxiety at the time?
And when I had symptoms, yeah, definitely.
I mean, I'm not sure if at the time that was what was the trend, but the trend has become to look at it more as something that requires psychological support.
Again, it depends on the person. I mean, there are some people who clearly have emotional issues, and they have symptoms constantly. Okay. And those people do need to be treated either, with psychotherapy, medications, what have you. Then there are people who have episodic symptoms, and what you just do is support them through those symptoms. So it really depends on the person and how severe the disease is. One of my brilliant teachers once, he wrote a book on it, and he said irritable bowel syndrome is not a disease that will kill anyone, although some patients wish it would. Yeah. So it really depends on the person. Right. So you have to be, you be more aggressive with people that are sicker.
Okay. One of the other things that a colonoscope might diagnose is a diverticuli. Anybody ever have a diverticuli mentioned to them? Oh. So here we are, our medical encyclopedia. Now, was this just an incidental finding, or was it something that was causing symptoms for you?
It wasn't causing any symptoms. It was the same time they found the cancer, they found diverticuli, and I've had diverticulitis twice since then.
Okay. Well, tell us a little bit. Oh, here you have another picture.
Oh, what do you know?
Actually, that's a really informative one. You did that with a sleight of hand. Tell us what a diverticulum.
Well, diverticulosis, everybody always asks, what's the difference between diverticulosis and diverticulitis? Well, diverticulosis, anything itis in medicine is worse because it means something's inflamed. That's easy. I think that was first day of medical school, wasn't it, Russell? That was
Yeah, I think that was
I paid
an easy
attention
one.
that day. After that, I don't know. But anyway, diverticulosis are pouches, pockets in the colon, as if you had like Play-Doh and you stuck your finger in it and it stuck out. That's what happens in the colon in some people. And it's because of a weakening in the wall. And the reason for that is we don't know. And again, it may be diet-related because they find in Western civilization where we eat a lot of meat, not enough fiber, we see more of that. You go to some of the countries where they have lots of fiber, no meat, no fat, they don't get it. So is there a link? It's an epidemiological association, so you make the call. But anyway, we know we have a lot of that in this country. And usually, it's an asymptomatic thing. People don't have any symptoms, you find it on colonoscopy and it's not a problem. In about 5 to 10% of people, they will have problems. What do they get? They can bleed, just spontaneously bleed without any pain, or they blow out like a tire and become infected, and that's diverticulitis. And those are the two things that can happen.
Okay.
That is a very common problem. About 60 to 70% of people over the age of 50 will develop diverticulosis, so it's very common.
So what we've learned today is there are a lot of diseases that people can get that can be diagnosed by colonoscopy, in particular colon cancer, and we see people here who had the diagnosis, some made with symptoms that suggested, but many without. So it's an important thing for you to follow those instructions from Dr. Garone. If you're at low risk, then at age 50 you start. If you're African American, you start at 45. And if there is a family risk, talk it over with your family doctor, your gastroenterologist. I want to thank you all for being here. I want to thank Dr. Garone for helping us learn everything there is to know. And until the next time, I'm Dr. Russell Libby, looking out for your health. Thanks.